Глубоко уважаемый Игорь Николаевич, уважаемые коллеги, большое спасибо за приглашение. Прежде всего, мне хочется сказать спасибо Валентину Евгеньевичу Синицыну, нашему президенту, и компании Bayer, которая сегодня в России вкладывает огромные усилия в обучение и в развитие лучевой диагностики. Большое спасибо за приглашение. So then I'll continue in English. And the topic of the report, excuse me, there's a timer which says that I have 1 minute left. But I'll try to squeeze in. So the topic of the report is quite widespread and well known nowadays. But still there are many confusions exist about the practical application of MR. Most of people can say that this is just T2 weighted images. What's to talk about more? Everything is so simple. But there are actually many things. But I'd like to start from agenda that these are the main topics that I would like to cover in my presentation. So a few words about prostate cancer, about our counterparts, the urologists, and about their expectations, about MR implementation, detection and staging, treatment guidance, and technique limitations. But I'd like to start with, from this beautiful picture, the night view of the world, which shows the lights around the world and in different countries. So here's the Russia. You know that this is our country where, and you can see those light dots. So what are they? This one is St. Petersburg. This one is Arkhangelsk, Moscow, Transsib, Yekaterinburg, Novosibirsk, Vladivostok, and Khabarovsk also there. And these are beautiful places that we have now in Russia. And this is Moscow. Moscow State University, you can see it here. Novodevichy Convent, not far also from the same place. And this is Moscow Medical University, where I had my medical school. And in this building, actually here, there is a ward where Lev Tolstoy came to visit Anton Chekhov. So this is the historical building and historical place. But since that time, prevalence of prostate cancer, I think, decreased million times. I'm not sure that anybody knew about this disease at this stage, because it really became the disease of 21st century. And we should remember that in 10 years period, the prevalence of prostate cancer in Russia rose 155%, so this is really incredible. Many of those cancers are not significant, not clinically significant. We'll talk about it later. And the major classification which is used for those tumors is the Gleason score. And I'd like to ask you to pay attention to those scores here, and especially to the score number 3. You can see here that the cells are pretty much similar to grades 1 and 2. We still see cells here in Gleason score 3. It means that even microscopically, sometimes prostate cancer is difficult to be diagnosed from for example, PIN, prostatic intraepithelial neoplasia. And especially on MR, we don't really good in differentiating this stage of prostate cancer. We are absolutely fine in looking for the cancers of Gleason 4 and 5. This is really important. But here you can understand why we are not very good in MR differentiating of Gleason 3 tumors. There is a number of options for treatment of prostate cancer patients now. Some of them are listed here. And of course, the major parameter that defines the treatment is the localized or locally advanced cancer or metastatic, so the spread of the disease. And patients can have from different options, from active surveillance to radical surgery, including nerve sparing, so with preserving of potential of the patients, and to palliative treatment in some cases. Now there is concept which is very important of high-grade prostate cancer, of clinically significant prostate cancer, because not every prostate cancer is really important for the patient. Not every patient dies because of prostate cancer, but many die with prostate cancer. So cancers of primary Gleason score 4 and primary, secondary, tertiary Gleason score 5, those are high-grade cancers. And currently, to predict the risk of disease with dissemination, the nomograms are routinely used, and in patients with moderate risk of metastasis, actually pathological T3, so locally spread disease, has a percentage of 50%. So those classifications are not really reliable to differentiate patients. What urologists expect? They want us to increase detection and to reduce over-detection of the tumors. And there is also potential to improve risk stratification, so to define which of the patients, which treatment method actually needs. And this is also very important for informed treatment decision making. Typical cases for urologists, patient with borderline PSA, no palpable nodule, doubt about indications for biopsy. Should we do MR? Nowadays, yes, we should do MR. Staging of prostate cancer, MR. PSA recurrence after radical prostatectomy, assessment of prostate bed and lymph nodes, yes, we should do MR. And MR significantly improves treatment selection and survival. This is publication from Journal of Urology 2013, so just recent one. So these are the roles for the imaging in so-called monography, not mammography, but monography. These are multiple ones prior to biopsy, and there is tendency now to do more MRs before biopsy, not to wait 1 month afterwards, because patients get really nervous. So we better do MR in the beginning and then continue for the biopsy. This is typical scenario which increase in popularity now. Stratification, staging and treatment planning, guiding therapy, and recurrence diagnosis. This is the general approach that is used now and propagated by European Society of Urology since 2012, when PIRADS classification has been developed, and this publication was very important. So now we have different protocols actually for MR staging, for nodes and bones, and for detection of the tumor. The general approach to introduce MR of the prostate looks like this. So we should have a team of urologists, radiologists, pathologists, always in cooperation, and dedicated MR technician who really knows how to perform the technique and also can introduce endorectal coil him or herself, so not to take physicians or radiologists' time for this. And of course, the major thing is communication between all the counterparts. This is something that defines the success of the program. And we have to remember for the interpretation, again for communication, that 1/3 of prostate MRIs with elevated PSA are normal. So we shouldn't be afraid to make the conclusion about absence of signs of prostate cancer on the MR, even in spite sometimes of the positive biopsy. It is harder, of course, to make a negative interpretation just psychologically. And we should also avoid overdiagnosis of cancer and extra capsule extension, because it can radically change patients' treatment plan. So I call it that's impossible trap. If someone says that that's impossible to introduce new method of diagnosis, you should actually understand that according to this person's very limited experience and narrow understanding of reality, that's very unlikely. But in fact, it's likely. So we really can introduce many different methods of treatment. And even for the world's greatest radiologist, the introduction of prostate MR or the routine can be hard to establish, because urologists' expectations are high. There is a lack of knowledge about clinical context about particular patient. MR is always busy, and we should explain MR usefulness to patients and to clinicians. And of course, learning curve is inevitable. So we collect the team of radiologists to really defend ourselves in front of clinicians who sometimes get very angry. They want to have the most information, as much information as possible, most of all. And with team approach, of course, we can deal with it. The key elements are, of course, magnet, which should be at least 1.5 Tesla, with the number of channels really matters. Endorectal coil should be used maybe in 50% of cases, but not always. So it's not something that you should use forever and ever. And we should remember about endorectal coil artifacts correction, because sometimes systems which are provided, they don't have this option, and images are really bad. Patient preparation is important. Personnel should be trained. Computer-aided diagnosis is useful now for prostate cancer imaging. There should be standardized interpretation on basis of PIRADS, and there should be systemic comparison with pathology. So we should get feedback from pathologists about what's going on with specific patients, and actually go to a pathology laboratory and discuss the cases. And with this, we can even start making studies like diffusion-weighted imaging of the body, which is getting now more and more popular. Yesterday's session was overcrowded. What are the patients' experience? I searched through the internet just to see what patients think about prostate cancer imaging. So not all of them are really beautiful citations, but for example, one patient says that it was very painful, and the biopsy compared to MR was a piece of cake. So that sounds strange. Another patient says that it's not terribly painful, so it's better. And the same patient says that he had a color Doppler done in clinical trial at Jefferson, and that included a lot of probing, so introducing the ultrasound probe. And the patient walked out like a greenhorn after the first long trail ride at Dude Range. So too much of the endorectal studies has been performed. So MR is better compared to this approach. Another patient says that MR may be slightly uncomfortable. And the citation, which of course I like the most, patient says it's not anything to fear. We're all in agreement on how important and how great this procedure is. It has kept this patient in the active surveillance mode for many, many years. So patient postponed the radical treatment because of MR. So MR really allowed to preserve the patient's quality of life. That's what we should do now. We should position the coil correctly, not like this. That's what many people actually do. We control the position by images, by localizer. We should position the coil correctly in terms of rotation. Sometimes also some specialists do like this, so coil corrected, prostate is deformed. We should get rid of this shining artifact, so these are all technical problems. And we should utilize PIRATS, which is standardized classification on the basis of Likert scale, which is scores from 1 to 5 for different image sequences. We use also dynamic contrast enhanced images with 1 millimole contrast agent with Gadavist usually, which is really good for this application. And we had a paper published in European Journal on diagnosis of recurrent prostate cancer with 1 molar contrast agent. And with PIRATS, we define probability of clinically significant prostate cancer. I hope you remember it in the beginning of the presentation. What is significant? So this PIRATS brings me to the idea that, to the citation of Sir William Osler, who said that medicine is a science of uncertainty and an art of probability. So we still work with definitions of probability. This is one of examples of patients with multimodal imaging, PSA about 5, so gray zone, normal digital rectal exam, and ultrasound. On MR, there's lesion of PIRATS 4 to 5 in the right lobe, and according to spectroscopy, there was lesion in the left lobe. On biopsy, the lesion was found only in right lobe, 3+4, and on radical prostatectomy, 3+4 in both lobes. So MR was completely similar to results of pathology analysis of resected gland. Sometimes ultrasound misses prostate cancer, and that's not unusual. So this is an example of patient with locally spread prostate cancer with invasion of membranous urethra and corpus spongiosum. So this is actually T4, missed by ultrasound. That's why for these kind of cases, we need to do image-guided biopsies, not only truth-guided biopsies, but MR-guided biopsy, or combination MR truth fusion-guided biopsies. So the fusion can be achieved in different ways. It can be just by your mind, by looking at 2 different pictures, which is widely used, or we can utilize special hardware to combine the images in one situation. So the radiologist anyway defines the lesion and reports with pictorial and schematic display. So we should indicate for clinicians slice, findings, and level of suspicion, because we are urologists' eyes to find the exact lesion. Without us, they can make the wrong diagnosis, underdiagnose or overdiagnose. So these are results of application of fusion MR truss biopsy, and you can see the conclusion. In men with clinical suspicion of prostate cancer and enlarged prostate due to benign prostatic hyperplasia, MR ultrasound fusion biopsy should be considered as first-line diagnostic approach. So this is not something about theory. This is exact practice, how it should be done nowadays, and you see much better results with this combination. Another combination which we can do, so we obtain MR images, we analyze them, then we have ultrasound, and then we target biopsy with real-time fusion. And compared to standard 12-core biopsy, MR transfusion-guided biopsy increases Gleason score in 1/3 of patients. So without it, we make underdiagnosis. So this is extremely important to bring MR out of only radiological application to joint application with urologists and to provide them with those images for correct navigation. And you see here, for Gleason 6 biopsies, many cancers were missed by target biopsy, but we are not really unhappy about it because these are Gleason 6, these are not important tumors, but among tumors with Gleason 7 and Gleason 8, most of them were missed by standard truss-guided biopsy. So it's much, so MR-guided biopsy is much better now, actually. So to come into conclusions, I'd like to say that dialogue with clinicians is extremely important. We need to help them. They don't really understand the images in, I think, okay, let's say in 50% of cases, but they think that they do understand. That's why those types of applications are very useful. And this is Android app that you can put on your phones, not iPhones so far, but on Android phones. And you can utilize to make the schemes of the diagnosed prostate cancer very useful. Okay, I'll skip this. So take-home points. First of all, MR detects and rules out clinically significant high-grade tumors. Specificity and sensitivity are very high. If we use a standardized approach, we should use MR for high-grade prostate cancer, not for any. MR has limited value in small cancers and Gleason 6. MR is gaining acceptance for prostate cancer active surveillance. MR transfusion becoming an office-based procedure. And for successful prostate imaging program, we need communication between urology, pathology, and radiology. And those do's and don'ts, I'd like just to summarize them in the end. So what we should do and what we shouldn't do. Do talk with clinicians and define what is accepted as clinically significant tumor, because we don't really find all the tumors. Do as many MRs as necessary. Do MR before biopsy, and do MR fusion-guided biopsy. And don't try to detect any prostate cancer. That's impossible. And don't be afraid to underestimate focal and minor capsular involvement, because this doesn't really change the approach for the patient treatment. So I'd like, again, to thank and to say that from 2006, then there was Russia, ECR meets Russia first time, and till this year, so many years has passed, and we are very happy that now we have Russian president. And I'd like to invite you and also to get you acquainted with European Society of Medical Imaging Informatics, which has just actually appeared last year, very active, and the conference will be in Warsaw in September. And to another directions, this is annual management and radiology course in October in Bologna, and our local course in Moscow, which is also ESR associated, which will be in April. And here is website. So thank you very much for your attention. Спасибо за внимание.